Good afternoon to one and all present here. On behalf of Holy Family College of Nursing, Obstetrical and Gynecological Department, I take this opportunity to welcome you all to this event today. We are going to attend a session on normal childbirth, and for this event we have with us, and I would like to welcome our Principal Ma'am, Madam Medicalized, Vice Principal Ma'am. We also have with us an expert speaker, Madam Miss Gail Perks. She is a midwife consultant in NHS UK. Ma'am has total 45 years of experience in nursing, out of which 25 years of experience in midwifery. Ma'am is going to take a session on normal childbirth based on the physiology, and ma'am will be explaining about how different positions can be adopted for childbirth. So I welcome you, ma'am, for this event, and I hope that everybody is going to pay attention and listen to this informative and insightful session. Thank you. Over to you, ma'am.
So, good afternoon, everyone. Thank you very much for attending. It's lovely to see so many faces here this afternoon. I'm interested in my favourite subject, which is normal birth. And I assume you are interested and your tutors didn't make you come. Is this correct? Okay. So my career in nursing started 45 years ago. And once I qualified as a nurse, my specialty was intensive care unit, which I loved, until I didn't love it anymore. Okay, I had my own family, and I was no longer so interested in the patient. It's so easy, isn't it? Patient is ventilated, sedated, cannulated, everything's draining. Not easy nursing, I know. But I wanted to become involved in women and families, so I changed to midwifery, and here I am. So in the UK, you understand that our model of midwifery and nursing and obstetric care is different to what you have here in India. Everybody understands that, okay. And so we have an expression in the UK that says, all pregnant women need a midwife, but some also need a doctor. And what that means is that if a woman is well and healthy, and her baby is healthy, then all of that care is led by a midwife. Antenatal care, intrapartum care, postnatal care, everything led by a midwife. If at any stage we recognise that the woman is unwell, or there's a problem with the baby, or she has coexisting morbidity like cardiac disease or diabetes or something, then we refer her to an obstetrician. And obstetricians and midwives are partners in care. And therefore, in labour, her care would be led by an obstetrician, although probably I'm giving the care, the ultimate decision-making is with the obstetrician. So let's just look back, because our title is Normal Birth, to those women with whom we are anticipating a normal birth experience. And I hope you can appreciate, therefore, how rewarding my role is when I can care for a woman throughout her pregnancy and labour and postnatal. Very rewarding, okay. And I know that in the UK, we have seen many Indian nurses and doctors coming over to the UK and converting their qualifications. And you are always very welcome, of course, but sometimes we feel a little guilty that we're stealing all your talented people. Okay, so let's move on with the presentation, as we are a little bit late in starting. If we can just move on to the next slide, please.
Next slide, please.
Not happening? So while we're waiting for this technical interval, may I ask you all a question, actually 2 questions. First of all, is there anyone in the room who is particularly interested, once you've finished all your studies, in specialising in labour care? 1 person. 2, 3, 4. Not many, but thank you for those that are interested. So my mission this afternoon is to convert many more people to be interested in my profession. Okay, so we're still not quite resolved. Okay. So my second question, related to the slide I was intending to show you, is this. Okay. Let me just talk you through these pictures a little bit. So on the top left, we have a mother who's just given birth. In the bottom left, we have a mother who is labouring naturally. You'll notice that she's standing up. She's supported by a midwife and she's supported by her husband or partner. It may be a partner in the UK. So in the bottom right-hand picture, we have a mother who has just given birth in her own home, which is safe in the UK, not safe in India. The traffic's too bad to wait for the ambulance. It's okay in the UK. And she's given birth in water, which is very normal for our practice. And I will mention water birth today, but may I just emphasise that this is only safe in the hands of people who are trained and skilled. And the top picture I'd like to show you, I hope you can see it, is that this mother has just given birth, and she has given birth in, as a midwife, my favourite position for giving birth. She's kneeling. You may never have seen this before. This is a wonderful position for labour and birth, and gravity is helping her, and as a midwife I can clearly see everything that's happening at the perineum. And all I need to do is just provide a very safe pair of hands to catch the baby. So do we trust birth? Can we do the next slide as well, please? Okay, so very different pictures here. Can you see the contrast? This is what we call medicalized birth. Okay, so for some reason these women need to give birth in a high-risk unit. There's a problem with the mother, there's a problem with the baby, there may be a problem with the labour. And high-risk units and high-risk intervention saves lives. Let's be very clear about that. But you can see that the birth experience for her is very different. Yeah. We have a medicalized type of room. And in the second picture, I chose this to show you that even for mothers with high-risk factors, this is a position that we do not recommend ever for labour or for birth. And in fact, our clinical guidelines that are evidence-based, and we are expected to comply with our clinical guidelines, very clearly says, for labour and birth, do not adopt a supine position, because this causes many problems. And yet, I think, let's all be honest, when you see pictures and images of mothers labouring and giving birth on television, YouTube, Netflix, all these things, usually this is what you see, isn't it? Yeah. So therefore, mothers think that this is what they should do. I should come into the room and lie down. Because it's a hospital, isn't it? And there's a bed, so therefore I need to behave like a sick person and lie down. Okay. Please remember that for most women, pregnancy, labour and birth is a normal physiological event. It's not a medical event, it's a surgical procedure. It's a normal process. And the woman is very well designed to do this. It is us that has turned it into a medical event. Okay? And we work very hard in the UK to try and demedicalize as much as we can. And I'll give you an example of that later on in the presentation. But in answer to my questions about whether we trust birth or not, do we? Generally. I'm glad that you do, but if I was to ask this of pregnant mothers and generally people, they usually say no. Because I think that's how birth is portrayed, as this big emergency with people shouting and screaming and a lot of drama. Yeah, that's what we see. So we don't trust this very normal process. And I want to help you this afternoon to learn that you can trust this process by understanding how it works. It's well designed, so let's develop some understanding about that. First of all, I'd like to tell you a story. And I'm going to tell you a story about a mother called Sangeeta. And Sangeeta was in labour. It was in the afternoon. And really what she wanted was she wanted a private room, a quiet room, where she could labour and give birth in peace and privacy and calm. But she couldn't, because her other little ones were awake. And they were busy, and they were playing, and they were noisy, and they were pestering her for attention. Where really all she wanted was to be quiet and on her own. So she managed to get through the afternoon and the evening. And as the evening wore on, and it became dark, the little ones gradually fell asleep. Thank you, God. And then finally, she had quiet, she had calm. It was peaceful, she had privacy, and she gave birth. Now in the morning, when she woke up, and her little ones woke up, they were very excited. So they went to find her. And this is what they found. Next slide. Billy? This is exactly the same for the human mammal. We are all mammals, and we all crave the same things for our labours and births. So those of you with some experience of labour and birth will know that most babies are born at night, aren't they? Yes. If you want many, many births for your training, you're going to be up at night. Okay. Why is that? It's because women crave this privacy and safety. So at night, as mammals, there are fewer predators around at night. So we can avoid those. But also at night, there's fewer of our own species around. They're all asleep. I'm trying to emphasize how important privacy is during a labour and a birth. And just compare that with the images that you are familiar with. Okay. Let's move on to the next slide. In promoting normal birth in this way, we do attempt to reduce unnecessary interventions. We recognise that obstetric interventions save lives. That's very, very important. And my practice is always in a clear framework of safety. But we also recognise internationally a huge rise in interventions, and we have to question, did we really need all of those? Or is there something about the way we care for women that is producing so many interventions? Can we do the next slide, please? So let's look at some of the mechanics of labour and birth. And I'd like to, although I have a pelvis up here, I'm actually going, oh no, it's not a pelvis, it's a uterus. Perfect, okay. I'm going to start with the uterus.
Is that working? Is that working? Yes. If you can hear me. No, not yet.
The back.
With this, I could feel I could give you a session in the gym now. Can you hear me okay? Yes. All right, great. Okay, let's continue. Okay, so I have my uterus here, yeah? So you probably can't see these long lines from the back, but these depict the longitudinal muscles of the uterus. This is the vagina, and inside here is the cervix. During contractions, all the force of a contraction starts at the top here, in the fundus of the uterus, and drives down these muscles to pull the cervix into the uterus. So as the labour progresses, the uterus becomes thicker and thicker at the top and more powerful. Now during contractions, the uterus likes to do something. I'll show you. It likes to do this. It likes to roll forward during a contraction. Okay? Like this. Okay. And those of you who have seen mothers labouring will be familiar with this, that when a mother has a contraction, she always does this. What can I find? Yes, you've seen this? She bends over. And if she can't find a piece of furniture, she'll find a wall or a person to help her to bend over. And can you see how this helps the uterus to roll forward? Okay, so just remember that principle, because that is a really key issue that's really important. Okay. Let me now move on to the pelvis, which we may have a slide of a pelvis. We do? Okay, very good. Okay. So pelvis, 4 bones. 1, 2, 3, and 4. Yeah? And during pregnancy, the action of hormones means that this pelvis becomes very flexible, yeah? Ready for labour and birth. This bone particularly important, the coccyx. It's a very special bone. It's rich in nerve endings. And all women who labour have pain here, but all the comfort measures in labour are focused here on the sacrum. Women particularly enjoy a massage, they enjoy a hot pack, they enjoy a shower. Anything hot on the sacrum is very comforting to women when they're labouring. So I explained that the pelvis is very flexible. Not hearing me? Yes? Yeah. And I want to just demonstrate a little bit more about that flexibility. Now, it's my understanding that every single person in this room is a student. Yeah? And are you therefore a student of anatomy? Yes? So everybody in this room has a skeleton. So I'm going to ask you to do an experiment with me. Might look a little strange, okay? But bear with me and we can demonstrate this movement in the pelvis. Can everybody please stand? never done before. Okay. So with the middle finger of your right hand, I want you to put your finger on this bone. Everybody has one. It's here. It's not rude. It's a bone. It's part of your skeleton. Okay? Got it? And you people at the back as well. Middle finger of your left hand, please, on your coccyx. Yeah? One finger here, one finger here. Got it? Okay. Keep your fingers here. Okay? You have to dig a little bit to find the coccyx. Yeah? Okay. Okay. Okay, I would like to see all hands on your pubic bone and all hands on your coccyx. Got it, everybody? Okay? It's more fun to join in. Okay? More fun to join in. Okay? Now, everybody imagine the distance between your fingers in centimeters. Yeah? Can you imagine that distance? Okay? Now, keep your fingers firmly in place, bend forward. Okay, and come back up again. Yeah? And one more time. Bend forward and come back up again. Okay? Well done, everybody. Please take your seats. So please tell me what happened to the distance between your two fingers when you bent forward? Increased. Everybody got that? Anybody not get that? Practice at home. Yeah? Okay. So you notice that the distance between this point and this point increased when you bent forward. Okay? So in fact the sacrum will move back 1.5 to 2 centimeters. Yeah? Simply by this position. Yeah? When mother bends over, like this. Okay. Are you impressed? Yes. Yeah? So look at this, these two little bones here. What are they called? Thank you. Okay. Probably the narrowest part that the baby needs to negotiate. Okay. Think of the images that you see of labour and birth. What position is the mother usually in for birth? Lithotomy. Everybody said it. This makes me feel very sad. Okay. Until the position I showed you earlier. Kneeling. Okay. All right. So why do we put women in lithotomy? What do we think happens to the distance between these two bones when we put her in lithotomy? What do we think happens? We think it increases, yeah? That's why we do it, because we think. But I'm going to ask someone down here, does it increase? No. Actually decreases. It actually makes the outlet smaller. Now, not everybody understands this. And if anyone in the room has had a lot of experience of observing women in labour, they will have noticed that in active second stage of labour, many women will bring their knees together because this flares these two bones apart. So if women labour naturally and instinctively, they will create an additional 30% more available space in their pelvis. Very different to lithotomy. Now, this is challenging for us, isn't it? When we think about our current practice, that we expect women to lie down, like this. So let's look at some of the issues lying down. There's three main concerns with lying down. Okay. So, if she's lying on her back, she's got a lot of weight, baby, pregnancy, amniotic fluid, gravity this direction, on her sacrum. What is she going to feel? Pain, yes, because this is very sensitive, okay. So this mother is going to ask us for pain relief. Epidural, very good form of pain relief. Not good for normal birth. Immobilizes the mother in this position. And there are many other issues associated with epidural that I don't have time to go into now. But with epidural, women are statistically more likely to require other sorts of intervention. At the very least, you know, she's got blood pressure, she's got double cannulas, she's got catheter, she's got oxytocin infusion, very intensive monitoring, and she's immobile. Statistically more likely to need instrumental birth. This is not my opinion, these are facts. We have researched this many times. Okay, she's going to ask for pain relief. All we had to do was move her onto left lateral, take the weight off here, and she would have been more comfortable. Okay, simple measure. Yeah. So, first issue is pain. Second issue, what does the uterus like to do during a contraction? Fall forward, come forward. Can the uterus do this in this position with weight and gravity? No. So, what we want is all of the force and drive of contraction concentrated on the cervix, to open the cervix. But in this position, the uterus has to work to lift up. So that energy is diverted away from the cervix into this, achieving this. Okay. So this is the labor that slows down. Contractions less powerful, less frequent, not dilating the cervix. Some people may diagnose obstructed labor, prolonged labor. What can we do? Well, what a lot of people will do is start an oxytocin infusion, yeah? But if we just stood her up, if we just did this, the labor is most likely to resume and become more efficient again. Have any of you seen this? When you care for labouring women, as soon as they stand up on their feet, oh, that labour becomes much more effective. So we've affected pain and the efficiency of the labour. Then there's another issue, okay. On the maternal anatomy, the mother's heart, about here. All of this weight and the force of gravity compressing major blood vessels around the mother's heart. This causes hypotension in the mother and causes hypoxia in the baby. So we have caused the problem. We have created the problem. We created the hypoxia in the baby. This point is so important that it's in our guidelines, in our national guidelines. Do not adopt supine positions for labour and birth. It's that important. And when our guidelines address hypoxia in second stage, the wording is perform intrauterine resuscitation. That language is very strong, isn't it? Resuscitate the uterus, turn her on her side, put her onto left lateral. Are you feeling a little challenged by this? Okay, so this position impacts pain, it impacts the progress of the labour, and it impacts the well-being of the baby. Just out of interest, does anybody know what the first rule of medicine is? Very first principle of medicine. First, do no harm. Yeah? Is this harm? It is. It is. It's very challenging. Okay. Could we please move on to our next slide? Thank you. So this is funny in the UK. It's obviously not funny in India. Okay, because this is a picture of an animal that is stuck on its back. And we don't want our women to feel like that in labour and birth. Stranded, helpless, cannot get up, okay? We want our women to feel that they are active in this labour and birth, that they are a partner in this labour and birth, that they participate. Everything is communicated, decisions made by her, and that she's not just passive like this, passive recipient. She actually owns her labour and birth, and we work together to achieve a good outcome. Can we do the next slide, please? Okay. I hope I've already impressed upon you, when I told you the story about Sangeeta, the importance of privacy for labour and birth. And these pictures here are a couple of examples of some birth units in the UK. Obviously these are water births, but if you can see that the room is very soft, there is some very pleasant wallpaper on the wall, and it's private and quiet. So these are the kinds of conditions that we try and achieve for our mothers. And even our mothers that are high risk, there's still a lot that we can do, even for those mothers. Shall we do the next slide, please? Okay, so mind and body, are they connected? Okay. Let's have a quick revision on hormones, because I'm sure that many of you know this already. I won't give you a test, but I would assume that you probably know this. So oxytocin, we like to call the hormone of love. Present throughout the reproductive cycle. Oxytocin is an ejection hormone. It ejects things. It ejects an egg as it wafts along a tube. It will eject sperm. It will eject a baby, placenta and membranes, and it will eject milk. Now it's easy, as it's the hormone of love, with the right environmental conditions to produce much more oxytocin. Oxytocin drives contractions. Remember, it ejects. It's a really key thing to remember. So in the right conditions, women will produce a lot of oxytocin. But in the wrong conditions, the reverse can happen. Oxytocin likes privacy, soft lighting, no other people around, no unnecessary talking, no cats or dogs or children. In fact, oxytocin in the bedroom, to work properly to make a baby, needs all these things. Think about the bedroom. Perfect place for producing oxytocin. And the birth room is very similar to the bedroom. Same parts of the anatomy, same hormones at work. So if you think about what people need in the bedroom, that's what they need in the birth room. So in the bedroom, if mother-in-law comes in, hello, no babies are being made. Yeah? Same in the birth room. Yeah. No unwelcome other people there. When you produce oxytocin in a little part of your brain called the hypothalamus, it stimulates the production of another hormone, I hope it's up here, endorphins. Okay? Endorphins we call the hormones of pleasure because they contain opioid properties. They are nature's natural pain relief. And they are produced in situations of extreme physical activity. So, running a marathon, going to the gym for an hour. Anybody do these things? You produce endorphins. They're also addictive. If you run every day, you want to run every day. Anyone can relate to this? That they are addictive? Thank you very much. Okay. If you don't run every day, you don't want to run every day. That's the other problem. Okay. So they have sedative-like properties. They're a comfort measure. They're a type of pain relief. And they enable a mother with a contraction, which is painful and challenging. It is like an attendant dose of pain relief. And they help a mother to become very quiet, very inwardly focused. She doesn't want to talk to you too much. She doesn't want to look at you. She doesn't want to have any conversations with you. She almost enters an altered state of consciousness. Anybody in the room had a lot of experience watching labouring women? Here? You have seen this? Women who just inwardly focused, introverted, they don't want to engage with you. She's producing a lot of endorphins. So painful contraction, dose of pain relief to go with it. What a great system. Works really well. When she produces endorphins, she then stimulates the production of another hormone called prolactin. Can you guess what prolactin does? Production of milk, thank you. It doesn't eject milk because that's what oxytocin does, but it makes milk. So what an amazing system. Powerful contraction, gives birth to the baby, placenta membranes, baby's born, and the body can actually make milk to feed the baby. Amazing, absolutely amazing. However, let me introduce you to another hormone. You're all familiar with this hormone, and you can probably tell me a lot about it. The hormone is adrenaline. Yeah, nods all around the room. Okay. So what is the simple term that we use to describe what adrenaline does? You said it. Louder? Everyone hear that? Fight or flight hormone. Okay. So what that means is that adrenaline is produced in a situation when we feel in danger or threatened by something. We're in fear. So there's a predator. There is something. Let's say it's a Bengal tiger. Probably not very likely in Delhi, but we'll use a tiger. Okay. So we have to either fight the tiger or run away to a place of safety. So our body produces adrenaline. And adrenaline diverts oxygenated blood away from the parts of the body that we don't need towards the big muscle groups and brain, vital organs, so that we can fight or that we can run away. Let's just imagine for a moment, there's some lovely monkeys in the grounds of the hospital here, I've seen them. Just imagine one of our monkeys is in labour, contracting, okay? And a Bengal tiger comes. So the monkey's going to produce adrenaline, yeah? So the monkey can run away for safety. What part of her body does she not need to fight or run, our monkey? What bit of her body is no use at all in fighting for survival? Anyone? I'm sure I'm hearing it, but someone's too scared to say it. The uterus, yeah, no use whatsoever in fight or flight. So oxygenated blood is diverted away from the uterus. So what's going to happen to the labour? It's going to slow down and stop, isn't it? It's going to slow down and stop so that she can run away. And once she's safe, up on the labour ward, upstairs, away from the tiger, this labour can resume again. About 30 minutes. Danger is gone, the labour will pick up again. Now, in reality, we're not likely to have any tigers on the labour ward here at Holy Family, are we? But there are other tigers. Okay, there are different kinds of tigers, okay, that produce adrenaline. The list is very long, but I'll just tell you a few. She's too hot, she's too cold, she's hungry, she's thirsty, the lights are too bright, you left the door open. I mentioned the lights already, didn't I? Leaving the door open. I don't like my husband, okay. The nurse is annoying me, the doctor is annoying me, there's a woman over there who's crying next to me in pain and this is making me feel frightened. All of these things, she can produce adrenaline. So what will happen to her labour? It will slow down and stop, yeah? So my role as midwife is to protect that mother from tigers. And if a labour slows or stops, my role is to ask, is there a tiger in this room? It might be another nurse, it might be the mother-in-law. It's probably the mother-in-law. She seems to cause all the problems. So my role is to remove the tiger and protect that woman, and that's your job when you are looking after women. And I've seen some lovely, lovely, lovely students on the labour ward. They're very, very interested, they're very keen to learn. But too many students equals one tiger. You know, too many students just not observing and not actually helping and becoming involved with that mother is a tiger. So I would recommend that we have maybe 2 maximum students at each bedside. And am I making this noise? If any of you are students, please offer some comfort measures to this mother when you're looking after her. Is that better? Is that better? You can hear me? Okay. Thank you. Oh, can one of you stay here actually? I can use you as a model for a minute. Can I borrow you for a minute? Yeah. Okay. Okay. So please be useful to your mother. So this is what I would expect of you. Okay. Hello. My name is Jo. Okay. I'm a midwife, and I'm going to be looking after you. Okay. Mothers like things like this. They like some firm massage when they're labouring. Can I touch your legs? Is that okay? Okay, calf down here. Yeah? Big muscles down here. Lots of firm massage. She likes this during the contractions. She really enjoys it. She finds it helpful. Thank you very much. Okay. So I did ask permission if I could touch you as well. Okay, so this is a very important point that we must remember, consent. Yeah? If we want to do something to a mother, we want to touch her, put anything in her, we must ask her consent first. And consent for an intervention should be based on information, not just, is it okay? Well, I don't know, is it okay? You tell me. I would like to rupture your membranes, is that okay? I don't know if it's okay. I'm a school teacher, I'm not a doctor, I don't understand. Explain to me, what are the benefits of this intervention? What are the disadvantages? So the doctor may say, well actually, I'm concerned about your baby. I'm seeing some CTG patterns that I'm not happy about, and I want to see the colour of the water. Are there any disadvantages? Yes, there are. But right now, the priority is this baby. Our mother is going to choose. Say, yes, please do this. This is important. But what about if the doctor says, well, actually, benefits. Well, I'm going home soon. And I want to see this baby born. I don't want to be here till 9 o'clock. Okay. So if I rupture your membranes, it's going to be much quicker. Okay. What are the disadvantages? Well, actually, labour can progress quickly, can be a lot more painful for you. But the benefit is for your convenience. Am I right here? What's the mother going to choose? No, thank you. You can leave my waters intact. But she has to have the information to make the informed choice. So always introduce yourself, please. Hello, my name is. This is my job. This is what I'm doing here. Okay. And may I please do this to you? And these are the reasons that I'm offering, whatever it is. Okay. That's the minimum standard that we should be offering. Okay. Let me just talk to you, we'll just finish on this slide with hormones. Just to explain a principle called pain-fear cycle. Has anyone heard of this? Let me just explain it very quickly. A little bit of revision for you. She is producing strong contractions. What hormone is she producing lots of? Oxytocin, thank you. She's producing lots of oxytocin. What does this stimulate the production of? Pain relief, yes. Okay. So, good contractions, pain relief, tiger comes in. Okay, small tiger. Maybe she left the door open. Woman outside here is crying, screaming, making a noise. What will she produce? Adrenaline. Okay. So when she produces adrenaline, what will happen next to her oxytocin production? It will decrease. Okay. So when her oxytocin production decreases, what is the next impact? Endorphin will decrease. And if her endorphin decreases, what does she, thank you very much, more pain. say tiger. Okay, so she produces more pain. So she produces more adrenaline. And can you see how this is just a vicious cycle that we call the pain-fear cycle? So when a labour is slowed down, or slowing down, not so effective, before you reach for the oxytocin and the amni-hook, think about tigers. Think about correcting what is the room, and I fundamentally believe that is my job. This is our job, to protect this woman. Okay. So, let's move on from hormones, if we may have the next slide. This was for, we can move on from that. We're not going to make reference to that one. Okay. So we'll just leave that slide there for a moment. And we don't have time, unfortunately, to go through every stage of labour. But I do hope that when you're being asked to assess women in labour, what are their contractions, I do hope that you're putting your hands on her abdomen, okay? And you're not looking at the CTG monitor because that is very limited information. You put your hands on here, you pull up a chair and you sit next to her for 20 minutes and you do nothing else. How strong is this contraction? How long does it last? What's the frequency? And you will soon see after 20 minutes, 30 minutes, is she having one contraction in 10 minutes or 3 contractions in 10 minutes? Is there a pattern? This is the only way you can tell. If a doctor ever says to you, tell me about contractions, I hope that you are ready to say, yes, I know exactly what's happening in these contractions. And you know the pattern of contractions is different throughout the labour. So early, latent phase of labour, until 5 centimetres, 1 in 10 minutes, 2 in 10 minutes, 3 in 10 minutes, none in 10 minutes, yeah? This contraction strong, this one not strong, yeah? No pattern at all. Mother can most likely labour safely at home once we have seen her. We can probably ask her to go home, stay mobile, stay active, and things will change. Active first stage of labour, 5 centimetres dilated to 10 centimetres dilated. So in this phase of labour, we're seeing a pattern of contractions, between 3 and 5 in every 10 minutes, and you can feel these. And very important, in between contractions, you feel that the uterus also rests. 3 contractions in 10 minutes might not be okay if the uterus doesn't rest for very long in between. Remember this, especially with oxytocin. You know, many babies born damaged and not alive is because of the overuse of oxytocin. So you need to be vigilant that the uterus is relaxing in between these contractions. Then we move on to, no, we haven't got that slide, transition phase of labour, end of the first active stage, just before full dilatation, yeah? Mother goes crazy. Crazy. I can't do this. I'm going home. I don't like the doctor. I really don't like that nurse. I want a divorce. I don't want a baby. I want a cesarean section, yeah? We have to work really hard with her at this point, okay? Let me help you breathe, okay? And we talk her through her contraction. Okay, big breaths, keep going, very good. Big breaths, keep going, well done. Bigger breaths, well done. We have to talk through every contraction at this stage to support her. Then everything changes after 10, 15 minutes of craziness. This, all of a sudden, mother is sleeping in between contractions. You've seen this?
Yes.
We call this the rest and be thankful stage. Okay. Body is preparing for the final pushing stage of labour. I can see the time is nearly 3:30. Am I okay for another 5 minutes because we started a little late? Is that okay?
Yes, ma'am.
All right. Okay. Let me tell you a couple of changes that are happening during this rest and be thankful stage. One thing you will notice is that sometimes she'll say, oh, Jill, I think I need to potty. I think I may have potty pressure. Okay, fine, whatever. That's okay. Not strong. Not every contraction. I can ignore this, okay? What's happening is that inside the vagina, if you remember your anatomy and physiology, there is very crinkly skin, curly skin called rugae, yeah? So during this phase, the rugae is straightening out. So the vaginal passage becomes very smooth and shiny, yeah? Ready for the baby's head to come through. And if we start push, 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 during this phase, she's going to get vaginal lacerations because that process is not complete. Let me also show you a really big change that happens. I hope you can see my uterus from the back there, okay? So as the labor progresses, the uterus continues to contract, becomes thicker and thicker at the top. At the point of full dilatation, baby passes through the cervix, and there's some space left behind. Yeah, about a third is left, okay? Rest to be thankful stage, latent stage, the uterus just needs a little time, just to regain its tone around the baby. Okay. And once that's done, once that is complete, then the uterus will continue to push that baby out. So important that we observe this quiet phase. How long? Primigravida, maybe an hour. Multigravida, maybe 30 minutes, maybe sooner. She has occasional urge to potty, whatever. Okay, no problem. It's not with every contraction. Then everything changes again. Okay, so she wakes up and she doesn't say, Jill, I think I have potty pressure. This time she says, Jill, involuntary. Every single contraction, overwhelming, irresistible, involuntary. She cannot stop. Her uterus is actually doing the work for her. And according to our national guidelines in care of labour, the second active phase of labour, the definition is the baby is visible. You can see it. And I mean you can see it when the mother is resting, in between contractions. Well, even in a contraction, you can see it. I don't mean you can see it by hands in, pulling this way, pulling this way. I can see way up there. It doesn't mean that, okay? It means you can actually see it. Now, why is this important? It's important because these phases of labour in our guidelines have a time frame attached. And if the time is finished, then some intervention is indicated. So we must use the time wisely. We don't want to be starting in this phase of labour, active pushing, because our body's not ready and we're going to run out of time. So active stage of labour, the baby is visible, and with every single contraction, overwhelming, irresistible urge to push the baby out. She has potty pressure, and that's when we start, and not before. Can't remember what's on the next slide, but let's have a look. Ah, very nice. We'll stay with that one for a minute. And it reminds me that an important thing that I have omitted to tell you. And that is, yes, there are some women in labour who will require continuous electronic fetal monitoring. And you may think, well, how can she be mobile and active in her labour when she has this? Well, she can be. She can sit up, she can stand, the leads are long enough, she can walk around a very short distance. So when I'm caring for women in labour, I don't make them do a lot of exercises. I don't make them do 20 lunges, and 50 squats and all these things. I don't ask her to do these things. Because I don't think she would do those things if she was on her own. We are designed to give birth alone, in case no one turns up to help me. The body gave you all you need to do this. So my gold standard is, what will this woman do? if I didn't interfere. What does she do? She changes position every 20 minutes or so. For 20 minutes, I'll use the ball. For 20 minutes, I will kneel up against the ball. For 20 minutes, I might stand over here. This is very nice, okay? Maybe I'll go to the toilet now. Yeah, a bit of walking, a bit of mobility. I may squat for a few minutes. Actually, I'm tired now. I'm going to lie down. So she can lie on her side for 20 minutes. So I encourage the mother to move throughout the labour. I don't rush her. I don't make her do exercises. But ask her to keep changing that position gently throughout the labour. And every 2 hours, please, out to the toilet, washroom, empty your bladder and walk back again. Also very good. Some mobility. She empties her bladder. Bladder emptying is important in labour, you know that. But also what's important in that washroom is privacy. You will be amazed how women progress their labours in the washroom, because suddenly that's the privacy that she needed. Yeah? Many babies in the UK are born in that washroom. Many. And provided you're there and you have a catch, it's okay. It's not a problem. We have known one mother call her baby Lulu because the baby was born next to the toilet. This is true. I'm told she had twins and the other one was called Flora, but I'm not sure that's true because that one was born on the floor. Lulu and Flora. Okay. But seriously, many mothers have given birth with me in the washroom because finally she finds that privacy. So every 2 hours, off you go. So you're moving her throughout the labour, gently into different positions. Okay. Some mothers, like to maybe 1 foot up on something for a while, or maybe the other side. These things are also good in the second stage of labour. And second positions in the second stage of labour are exactly the same. Your mother is not stuck on that bed immobile. She can still move around. She can still walk out to the washroom in the second stage of labour. So many mothers labouring instinctively will labour, in fact, upright. Does that surprise you? Yeah? Many will labour here. And as the labour progresses, she will increasingly get closer and closer to the floor, so that if she was on her own, her baby will not have an injury. It's just born onto the floor and the baby's fine. This is very instinctive for mothers. In the UK, many mothers give birth alone by accident. We didn't diagnose labour properly. We sent her home. She gave birth in the car park, in her own home, in the washroom. Unfortunately, we see this a lot. And what position are those mothers never in when they labour and give birth? I thought to me, when they're never in this position when you ask them. They're usually something like this. All fours is quite common. Kneeling is quite common as well, something like this. And another two very interesting things about these births, when there is no one there to direct, the baby's always fine. Always. And another very interesting thing, so is the perineum. How is this? How is this? The process of labour and birth was not designed to be pain-free. Nature gave many strong signals to the woman. And she gave those strong signals so it would drive her behaviours. This contraction is painful. If you bend forward, it is less painful. Yeah? And when it comes to the second stage of labour, exactly the same. The signals are so strong that the mother will respond to those signals for the well-being of her baby and for the protection of her perineum. So, positions in second stage. If we can do the next slide, please. Definitely no. And next slide, please. Next one. Okay. I think this is the last one actually, so stay there. Okay. That's fine. Okay. So positions for second stage: standing, squatting, kneeling, all fours, and if she's tired, left lateral. left lateral is a lovely position for labour and birth. And you can actually, if you have the opportunity, you will see the difference in progress in second stage between lithotomy and left lateral. Okay, and I just want to say something about pushing before I close. Okay, because this was meant to be about normal birth, wasn't it? That was the point of the conversation. So what would be normal, as opposed to what you've probably seen on Netflix, or maybe? So what you see on television is something like this. Take a big deep breath. Put your chin on your chest. Right. Push, 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 push. Yeah? And that's not one person in the room. That's probably about 6 people, you know. How can mother possibly? Yeah. Pushing a baby out is like having a potty. Sorry, but everybody in this room has a potty, so you're all nursing students, so we can just have this conversation, okay? If you're having a potty, is it going to help if someone comes into the washroom and shouts at you? Probably not. What will work well is if you wait until your potty is drowning. I'm ready. Yeah. Not too early in the day, yeah, because that would take a long time. Okay, so waiting until you're really ready for the potty out. And it's no effort. Yeah, it's not hard work. It's not difficult. So if you have observed the early second stage properly, the pushing phase for mothers is actually quite quick. You know, no more than 20 minutes, if that. Remember, the baby's visible. Yeah, everything is ready to go. And by the way, why are their perineums intact? Let's just have a little conversation about that. So, I'm assuming many of you in here have seen a birth? Yes. Yeah? Okay. So, do you remember the point? Kind of about here, just before full crowning. Okay. So what does that feel like to a mother? Well, I won't ask anyone here to explain because they may be embarrassed, but I can tell you that this is hot, burning, very unpleasant sensation to the mother. Yeah? She feels that when she pushes, I don't like this. This doesn't feel nice. Okay. So what's mother going to do? Stop pushing. She will stop. I don't like that. That's uncomfortable. And when she stops pushing, which she will do instinctively, the perineum can open slowly and evenly around the emerging baby's head. Nothing forceful, not this push, 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 go on, harder, 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 none of this business, yeah? Just the uterus does the work. So in our birth room, we say to mothers at this point, stop pushing. Just breathe. Not fancy breathing, not panting or anything like this. We just say, just breathe and stop pushing. And this, the perineum enlarges. You'll be amazed how much it enlarges. Yeah. And the perineum will often stay intact. In one birth unit that I worked in, 60% of women had no damage to their perineum. Yeah? And of the remaining 40%, about 20% of those were first-degree tears. And according to evidence, the natural tear is more comfortable for the mother, and the healing is better for the mother. Yeah? So routine episiotomy is a practice that we should not be doing. This is also in our guideline. Okay. So we're not going to give birth to the rest of the baby. And I'll just finish then with, you know about optimal cord cutting, don't you? You know about this. A third of the baby's circulating volume is in here after the birth. Yeah? How many babies over the years have we resuscitated thinking they're hypoxic, but they're actually hypovolemic because we cut the cord too early? 30% of circulating volume is a lot of volume. How long does it take for the cord to stop pulsating? How long is a piece of string? Some people say 2 to 3 minutes, some people say 4 to 5 minutes. If the baby's fine, it takes as long as it takes. It doesn't matter, okay? Important that someone is feeling the cord. So we cut when it stops pulsating. That's the right answer. When it stops pulsating, it's white and cold and limp, then we cut. And then very important that baby maintains skin-to-skin contact with the baby. Obviously this baby would be dried and wrapped, not cold in here. This is important for the baby. Babies cannot regulate their temperature. This is the warmest part of their mother. The action of oxytocin makes this part very, very warm. So she naturally brings the baby here anyway. Regulates the baby's heart rate, respiratory rate, and of course the baby can latch on and feed. And this is good for the mother. So a baby sucking on the breast, do you know what hormone is produced? Oxytocin, thank you very much. Oxytocin causes contractions. We need the mother to expel the placenta and membranes, yeah? So stimulation at the breast, the mother continues to contract, expels the placenta and membranes. And once they are expelled, continued oxytocin means the uterus will contract very firmly. There's many, many open blood vessels on the placental bed. You know how quickly women can bleed out. So we need the uterus to contract firmly. So skin-to-skin contact is beneficial not just for the baby, but also important for the mother. And the very least that we can do is we try and maintain this for 1 hour after the baby is born. Before there's many jobs to do. Mother wants a wash and baby needs to be vaccinated and measured and weighed and all these things, okay? So in your labour room here, it would be great if the paediatricians came to the birth, assess the baby, that baby's fine, I will return after 1 hour and do all the measurements and things later on. And then we just leave the mother with privacy for 1 hour, having skin-to-skin contact. This is what we should be aiming for. I know we're not there at the moment, but we can aim for these things. Okay. So in the time that I have had available to explain normal birth to you, I think that's all I can achieve today. I can promise you I could keep talking all day. I could talk underwater if I needed to. And there is much more that I could share with you, but I think that that's probably all the time we have available today. Okay. Please enjoy these lovely images that are behind me, if you haven't already seen them. These were water births, because this was designed for a water birth presentation. But I'm sure that you can see how relaxed the mother feels, and what a lovely image this is. And we all can contribute to this. Okay, so I think there may be one more slide, probably just, yeah, okay. Can I tell you one more tiny little story? Yes. Just one, small one, is that okay? Yes. Okay, this is a French story. Okay, so one day there was a very high tide, the ocean came in very far. And when the ocean went away, what was left behind on the beach? Many, many starfish were left behind on the beach. And as the sun was rising and it was becoming warmer, the starfish were going to die. And a little girl on the beach was picking up each starfish and throwing them into the water. And she was walking along the beach, throwing every single one into the water. And an old man observed her doing this. And he came to her and said, "What are you doing?" And she said, "Well, the sun is coming up, and you know, there's many starfish and they're going to die. So I'm going to put them back in the water." And he said, "Look, there's no point, okay? There's so many of them, there's too many of them. It won't make any difference." And she picked up one starfish and threw it in the water and said, "It will make a difference to that one. Have you heard this story before? Okay, so you can all make a difference. In whatever very small or very big way, you can all make a difference. And with that, I thank you. Okay. That's it. Okay, thank you very much.
Thank you, ma'am, for such enlightening and insightful class on childbirth. Your words have not only provided us with valuable knowledge, but also deepened our understanding of this profound and beautiful journey of life. Your expertise and wisdom have truly inspired us, and we sincerely appreciate the time and effort you took to share your experiences with us today. Thank you so much, ma'am. I now request our principal ma'am to please come forward and address the gathering. Yeah, please, questions?
My question to you is, first of all, I want to know that in UK, what about the pregnant mothers? You do prepare them before, during pregnancy, during their antenatal period? For labor?
You make a very good point, and it brings me back to my original slides about whether or not we trust birth. And absolutely, we invest a lot of time and place a lot of importance on the value of mothers and their birth partner attending antenatal birth workshops, because we want them to trust birth.
So on the behalf of all the Indians, and I apologize that we do this push, but my instinct says that because we do not prepare them prior, and they do get prepared from the relatives, from the layman, from the community who doesn't know anything by themselves, they says to them that this will happen. They make them fear. They made a fear enter into them that this will happen disastrously in the people room. And out of that, I think this all which comes. Yeah. So I think being a obstetric nurse, I should say that during the antenatal period, how much you can explain or counsel the mother, that would be beneficial. Yes?
Well, we provide labour and birth workshops, similar to the one that we had here at Holy Family at the weekend. So we provide these routinely, and we encourage all first-time mothers and their birth companion, whoever it is, if it's her husband, her partner, her sister, her cousin, her mother-in-law, she's welcome. Whoever will be with her needs to understand and trust birth. So we make this provision, we invite them to the classes. And if some mothers are too nervous to attend a class like that, we will try and give her a one-to-one lesson.
Any more questions?
Actually, I don't have a question, but I want to just say something. My grandmother, my mother, and they all are give birth in the squat position only, or squat position. Okay, because in my village nowadays also the deliveries is at the home, and all mostly are in this position, kneel-down position, or in the squat position only. But in India, when the institutional delivery is introduced, then only this lithotomy position came in. Otherwise, there is no lithotomy position in private. So when I see these my grandmothers or my mother, or nowadays also in my age people also, they are giving birth in this position only.
Ma'am, you mentioned giving left lateral position. So why not right lateral position has been preferred?
because of the position of the mother's heart. In that position, the weight will shift away from the mother's heart. Any other?
I think everybody has enjoyed the session. There was a lot of silence, and I could make out sitting in front also, everybody trying to hear each and every word, and it was not a boring class that you have in the classroom. I'm really thankful to you, and the time when we came to know that she's going to be there in our institution and came and we had a talk, from that time we thought that we are definitely going to use this opportunity. So that, the practices in India will take time to change. But at least we need to be updated on and work on how we as nurses, because we are getting registered nurse and registered midwife. So how we can make the change, how in future we can take care of mothers in a better way, fine, and not to have that threatening atmosphere for the mother. I think that lesson everybody has got. And we are sure that she's going to come back again. And we have more opportunity taking more and more sessions. Thank you so much. It was wonderful hearing you.
Thank you, ma'am. I now request our Vice Principal, ma'am, HOD Obstetrics and Gynecology, Professor Dr. Simil Babu, to speak with the rules. Thank you, ma'am.
Good afternoon to everyone. Thank you, Madam G, for such a enlightening session. I must say, telling the importance of normal childbirth following the physiology. Let the nature take care. I used to tell in all my classes, let the nature take care, because it's a normal physiological process. Either you are there or not there, delivery will happen. Your role is to assist and see and observe if anything is going wrong, and support the mother and give comfort as much as possible. Like Madam was telling, everything, any disturbance is annoying that can inhibit oxytocin production and can inhibit labor. So as much as possible, we will give privacy and be supportive and avoid any distractions, so that we will be able to give a pleasant childbirth. And now Government of India has come up with even Indian Nursing Council has come up with a new initiative, like you might have heard about midwifery initiative. It's a new initiative to promote midwifery practice and to bring the old childbirth practices which are normal, which promoting normal childbirth. You might have heard about midwifery-led units. It's already started, and it is going to be, even the training may soon start in Delhi also. So I hope some of you may opt for this profession, being independent midwifery practitioner, so that the rising rate of cesarean section can be reduced in India. Thank you, ma'am, so much.
Thank you so much, ma'am. Now, I kindly request our respected principal, ma'am, to present a token of our appreciation, a memento as a small gesture of our gratitude to Madam. We conclude, on behalf of everyone present here, I extend our deepest gratitude to you, ma'am, for your presence and for imparting such invaluable insights to us. Thank you so much, ma'am. Thank you to everyone present here for your attentive listening. Thank you so much. Have a great evening.